Okay, let's jump right into this. Welcome back to Decode Healthcare. I'm Harshal, and today we're tackling part 19 of our masterclass series. Today we're completely demystifying the complex rules of case management and care plan oversight evaluation and management codes. Look, we all know the dread of a sudden audit letter, right? Well, these are areas where leaving minutes on the table or just misinterpreting the CPT manual can lead to serious compliance issues and painfully lost revenue. So we're going to get into the weeds today and make it all incredibly simple. Here's our roadmap for today's explainer. We've got Welcome to Case Management, Medical Team Conferences Defined, Team Conference Coding Rules, Care Plan Oversight Services, Monthly Oversight Thresholds, and finally, Essential Rules and Wrap-Up. Let's get started. Section 1, Welcome to Case Management. Let's lay the groundwork here and see how this builds the foundation for billing complex, coordinated care. At its core, case management is really all about a healthcare professional actively coordinating, managing, and supervising the direct care a patient needs. You see, when a patient has highly complex needs, the work simply doesn't stop the moment they leave the exam room. The CPT manual actually gives us two distinct pathways to report all this extensive coordination. First, we have medical team conferences, which span codes 99366 to 99368. And second, we have care plan oversight services, which cover codes 99374 to 99380. Today, we're mastering both. Section 2, Medical Team Conferences Defined. Let's dive right into this first major category. So, the crucial point here, you can't just have a quick chat by the nurse's station and call it a medical team conference. To legitimately report these codes, you absolutely must have an interdisciplinary team. The CPT guidelines are very strict on this. You need a minimum of 3 qualified healthcare professionals, or QHPs. They've got to be from distinct specialties or disciplines. And here's the real kicker. Each of these participants must have physically evaluated or treated the patient within the past 60 days. If you don't meet that 60-day rule, you just cannot bill the code. And equally important is this number, 30. 30 minutes. That is your absolute minimum time threshold. If your team conference lasts 29 minutes, it cannot be reported separately. You have got to hit that solid 30-minute mark of active participation in the development, revision, or coordination of the patient's care plan. Section 3, Team Conference Coding Rules. Now that we know the basic requirements, let's break down the exact pathways. When we look at the official CPT guidelines for direct, face-to-face contact, code 99366 really stands out. This is utilized specifically when the patient or their family is physically present for the conference. But there's a vital caveat here. This specific code is for participation by a non-physician qualified healthcare professional. Why is that? Well, because if a physician is leading a conference with the patient present, they typically report that time using standard evaluation and management codes, not a team conference code. But here's where coders often get tripped up. What happens when the team meets without the patient or family there? That is exactly when we look at the next 2 codes. Code 99367 is used specifically for physician participation in a non-face-to-face team conference. And code 99368? That's the equivalent code for non-physician QHPs when the patient is absent. Just remember, for all of these, that 30-minute minimum still applies. You've also got to remember to check the specific exclusions before you drop a code. The biggest trap is the specialty rule. A maximum of 1 individual per specialty may report the service at the same encounter. You literally cannot have 2 cardiologists billing for the same team conference. Furthermore, you can't report these codes if your participation in the team is already part of a facility or organizational service you're contractually provided to do. And lastly, no double dipping. The time spent in this conference cannot be counted toward other time-based E&M services or care plan oversight. Section 4, Care Plan Oversight Services. Let's shift gears and explore the second half of today's explainer. Care Plan Oversight, or CPO, is reported separately from your regular facility or home visits. It represents the behind-the-scenes heavy lifting of coordinating a patient's care over a 30-day calendar month. We're talking about patients who require highly complex, multidisciplinary care modalities. This means the regular development and revision of care plans, reviewing subsequent reports, integrating new information, and adjusting medical therapy. What's absolutely critical here is how the CPT manual strictly divides these oversight codes based on the patient's specific setting. The coordination work might feel incredibly similar on your end, but you must select the correct code based on where the patient is primarily receiving their care. Is it home health, hospice, or a nursing facility? Section 5, Monthly Oversight Thresholds. To make sure you get paid correctly and survive an audit, we have to master the monthly clock. This coding matrix relies entirely on time and location. For oversight of a patient under a home health agency, you bill 99374 for 15 to 29 minutes in a calendar month and 99375 for 30 minutes or more. For a hospice patient, the codes shift to 99377 for the lower time tier and 99378 for 30-plus minutes. Finally, for a patient in a nursing facility, you're going to use 99379 for 15 to 29 minutes and 99380 for 30 minutes or more. Notice that anything less than 15 minutes in a month is not separately billable. And this leads us to an incredibly important rule straight from the CPT guidelines. The work involved in providing very low intensity or infrequent supervision services is not reported separately. If you're doing minimal oversight, well, that work is just considered bundled right into the pre- and post-encounter work of your routine home, office, or nursing facility visits. You have to hit that 15-minute minimum of truly complex coordination to unlock these oversight codes. Section 6, Essential Rules and Wrap-Up. Let's bring this masterclass home by cementing the golden rules you absolutely cannot afford to forget. Take a look at this exact language directly from the CPT guidelines. It is the ultimate rule for care plan oversight. It means you cannot have multiple clinicians billing CPO for the exact same patient in the exact same calendar month. Only one individual, the one reflecting the sole or predominant supervisory role for that patient's complex care, gets to bill these codes. So let's review these final takeaways carefully. For team conferences, you need at least 3 distinct professionals who have seen the patient in the last 60 days, and you've got to hit a full 30 minutes. For care plan oversight, ensure your documentation perfectly aligns with both the 15 or 30-minute time thresholds and the patient-specific care setting. And remember, only one captain steers the ship for monthly oversight billing. Understanding these rules conceptually is one thing, but applying them meticulously to your monthly time tracking is how you truly master E&M coding compliance. If your clinic isn't tracking these minutes cumulatively over the 30-day period, you are either losing out on well-deserved revenue for complex care, or worse, you're setting yourself up for a very painful audit. Take a hard look at your internal processes this week. Are you capturing every single minute of complex care, or are your practice's revenues slipping through the cracks of poor documentation? Think about it. Don't forget to like, share, and subscribe to Decode Healthcare with Harshal.